I hope the last 2 days has left you as inspired as I am. I mean, Larry's vision for a full ecosystem in healthcare. You heard from Safra about her laser focus on transforming not only Oracle, but all of our customers in ways that make their success key. And Seema's leadership, I think, really put us in an incredible place. I've had this opportunity to see healthcare from a lot of places. My name's David. I'm the chairman of Oracle Health. I'm trained as a child psychiatrist. I've had the opportunity to run a couple of health systems and lead both Cerner, Google, and now as chairman of Oracle Health. It really feels like it's an inflection point. So let me invite on stage my panel, and this is what we're going to try to do. I have an amazing group of panelists, and what we're going to try to do is really take you 5 years in the future and what healthcare is going to look like. And this will be the final panel of our Oracle Health Summit, and then Seema will close us out. So please, if I can invite the panel on stage. And we're going to try to make this very interactive, even though I feel like I'm far away from you, Sonia. So we're going to pretend like we're just having coffee, and it's just the 6 of us with a few people next door listening, okay? So we'll go through introductions as we go down the line. And so please do your own formal introduction, because I think you'll do a better job. But let me actually start with you, Sonia. So Sonia, to me, or let me start first with Dr. Harris-Haywood, and if you're okay with Sonia. Okay, so if healthcare is going to change, and if we're really talking about changing in 5 years, before we get to global, I think it has to start local. That healthcare, I've always felt that it's people caring for people, and it's based on trust. No matter where I go in the world, those are kind of the core principles. I had the opportunity yesterday with Dr. Hildreth to announce Oracle's partnership with Meharry. He said he's been, I think, the president for 10 years, but he described yesterday as his best day so far. And that partnership, I think, is a real opportunity for us as a tech company to come in and partner with a trusted healthcare provider and educator in this community to really do one thing and be able to show that to the world. And the one thing we're trying to do, I'll say it's kind of two, but the one that I think is absolutely crucial is if you go anywhere in the United States, or I would say anywhere, and we have a friend of mine from Australia here, anywhere in the world, you can see difference in life expectancy of 20 years just based on your zip code, or where the subway stops, or if you're on this side of the tracks or that side of the tracks. So this incredible technology and the spectacular doctors and nurses have not really fixed that terrible inequity. So what we want to do with Meharry, I would say what we want to do through Meharry, is with our announcement of moving our Oracle headquarters to the East River, to be able to say to the folks in East and North Nashville, we're going to do our best to close that life expectancy gap. And how we're going to do that is with your frontline care, and we hope with our technology that will actually bring out those inequities. And then, if you're okay with it, we want to show the whole world. So we want it to become our showplace that people will come and see what happens. So with that intro, can you introduce yourself, and you can also tell us for sure about the impact that Meharry has already had, particularly around making sure people of color go into health professions.
Well, thank you for that introduction,
Okay.
David. First, I will start with an introduction. I am Dr. Sonia Harris-Haywood. I am the proud, excited, happy dean of Meharry School of Medicine. I've been in that role for about a year and a half, and in that year, we have seen some great things, but I must tell you that we are so excited about what happened yesterday. This partnership is going to take this whole challenge of health inequities, health disparities, and move it towards a new story about health equity. Thank you for giving me this opportunity. Thank you to my fellow panelists, to Oracle. I'm just glad to be here representing Meharry Medical College. We're going to transform medical care. We're going to make that challenge that we have associated with who gets to live longer based on where they lay their heads, and we're going to do it with this partnership. As the Dean of Meharry, I work to produce the healthcare leaders of this country, and we produce them and they go and do what they need to do both here locally, nationally, and globally. We focus on moving the needle. We're living in an old narrative of health inequalities, health disparities, and we now have to start looking at what it means to look at a new story of health equity. Meharry's poised to do that. We are producing 27% of the dentists in this country are graduates of Meharry.
27, you said again, 27% of the Black dentists in the United States come from your university.
They come from our university.
That's spectacular.
80% of the medical students, residents, and faculty that we have right now nationally that graduate from Meharry, they are caring for the under-resourced, under-insured population in this country. And they're doing it in the context of primary care. This is their mission, this is who they are. We also know that in Nashville, $29 million we spend in this city attempting to take care of the uninsured. And we do that partnering with other people who are focused on that population. And then globally, we are helping to reduce the transition of HIV in African countries and other places. So we are out there. I'd like to say that our approach to addressing healthcare disparities and inequities and moving us towards health equity is really rewriting the story around workforce diversity, integrative healthcare, and innovative healthcare. Diversity in healthcare is critical. Because what do we know? What the literature has told us, that people, Black and brown, and minorities are more likely to go into under-resourced communities to practice primary care. And if we're going to change what's happening in those communities, we have to increase a number of people that look like me, that are Black and brown, who want to do this work, minorities in those communities. That's critical. But I want to take you a little bit farther, and I want you to imagine something. A 15-year-old coming in for a follow-up visit after his second gunshot wound in 2 years. Instead of focusing solely on the physical wound, the emphasis shifts in the visit to addressing the psychosocial factors that may make him vulnerable to repeated trauma. This holistic approach is the formation of care, this integrative care that our students are receiving every day. We're looking at the psychosocial determinants, the things that I heard Larry talk about that are going to be in that medical record that now I can get my access to. Because health and wellness are really dependent on this. And when we understand these factors, it's not an afterthought, but it's the core component of the treatment unless we think about it otherwise. One more thing I want you to think through. Imagine what access to high blood pressure, management for a minimum wage, hourly worker with insurance, but no PTO to go to the doctor. If she wore a wristband that monitored her blood pressure, that allowed me to download that particular data. Then she could be on her job at her lunch hour in her car having a televisit with me, and we could visit and I could monitor her high blood pressure. What's the beauty of that? We've now made access to care using devices accessible. That's the innovative healthcare that we are teaching our students at Meharry.
So we are all in and so excited about it. And General Crossland, we had the privilege of listening to you and Mike Cecilia this morning and got the overview of the Department of Defense health system and your amazing leadership. There's health inequities in the military, and there's the military that you're responsible for in a lot of ways mirrors the U.S. Tell me how you're thinking about this particular issue.
Well, it's great to be back this afternoon.
Yes.
Right?
Yes.
So for those of you I didn't have a chance to meet, I'm Tallulah Crossman, Director for the Defense Health Agency. And that simply means I have the honor of running the health system for the Department of Defense and our 9.6 or so million beneficiaries across the globe. Manage a budget about $60 billion. To do that, that includes research, so really love the conversation earlier on where the EHR is evolving from not just being a platform from data, but for also bringing other parts of healthcare, whether it be research, whether it be the business ends of it, all into one place so you can make good clinical decisions as well as good business decisions. So we have a vested interest in that. To your question, how do I see the opportunities that technology brings into medicine as we care for, first, a population that moves a lot. So you and I had a conversation backstage on how many places I've actually lived. And I moved about 19 times in my career. And you can imagine what that could mean for fractured, disjointed healthcare, even though I'm in the same system. Allowing my clinical data and my health data to move with me allows for a better experience for not just the patient, but for the healthcare system to deliver it. So we have a very mobile beneficiary population. Our population also serves in austere, isolated locations, either in combat, point of injury, disparate, isolated, remote, as well as in places in our own country where we have medical deserts. And so when I look at our healthcare system, we mirror some of the things that you see in the U.S. healthcare, but we have that other unique aspect of the operational environment. And I believe technology, and not just the technology, but the data itself and how we're able to harness it, use it both to treat, but to get into the space of predictive, is value added to our patients as well as to our military as we keep the force healthy and ready, which is one of our primary objectives in our health system. The second is to keep the medical force trained and ready to be able to provide care that's on time, but also we have to provide care that's scalable. And I believe technology also gives us that opportunity to provide care at scale such that it's not the luck of the draw that you happen to be in this location with access to this at the time of your event. We want to be able to scale across a large population and from austere locations and spaces inside the United States. And then I think very common to anybody in medicine is personal. We all have a stakeholder in it, either as a patient ourselves or as those that run healthcare systems and manage it. And I believe we have an enormous opportunity to get back to what I believe why I went into medicine, right? I'm a family doc, is ultimately to take care of a human being, to improve that human being's life. And I care about that human being even when they're not a patient, because the first part of health care is health. And so I think there's tremendous opportunity where now we can truly get into health. And that health has a lot of value to the DoD, both from the military aspect, but also for the the family members and retirees and all that we're entrusted to serve.
That's fantastic. General, in the history of medicine, so much has been learned from military medicine. The golden hour, resuscitation, trauma care, the list kind of goes on. You've spoken a lot just now and earlier today about health and wellness. What do you think we could learn in civilian medicine from what you're doing around health and wellness? Because that's way more upstream than trauma care, right? So I love your focus on that upstream piece. Teach us so we don't have to wait to catch up. So tell me where you think the pieces are in that kind of prevention, whole person care, health that you're thinking about.
Yeah, where we're moving right now is we've got to get better patient engagement. And so when I look at, as a director, when I look around at our society, if you will, patients and individuals are engaged when they have control. So moving us a little more into the space of partnership and engagement with our patients is one thing we're absolutely, and so you've got to value the patient experience. And I've said it a couple of times, I care about you when you're not in the exam room because that actually impacts your outcomes. So as a healthcare system, there's value in that. Getting our providers and our healthcare teams to move with us in this space and how we lead through that cultural change to get to that place where we do care about health and not just about how I can heal you and get you better, but I actually care about you and keeping you healthy. So getting tools so that our clinicians and our healthcare teams can spend time to do that, but can also value and do that. We don't do that not because we don't care. It's hard. It's hard to find the time. It's hard to see the data. It's hard to know what to do. And that's where I think the technology can be enormously helpful with data and leveraging data. And the last thing is we're lucky as a healthcare system. Luck is an interesting word, because some days it doesn't feel lucky. But right now, as a director, I'm responsible as the payer. So we run the health, we have a TRICARE, managed care support. So we purchase a lot of care in the commercial sector. We run a healthcare system, and our beneficiary population they're stable. And so we can afford to lean in and show a different fiscal model that says an investment in this year will pay off 3, 4, 5 years from now, and show the way for the rest of the country to truly lean into the value base.
Yeah, it totally makes sense. On that patient engagement piece, and you said you think technology can be helpful. When I was training as a psychiatrist, you'd get, therapy patient, and this patient would come and see me every Tuesday. And my supervisor said to me, "Do you ever think about your patient in between visits?" And I'm like, "Of course I do." "Well, have you ever said that to your patient?" I'm like, "No, am I supposed to?" Next Tuesday, patient comes in, and I had thought about the patient over the past week, and I said, "I've been thinking about you." Unbelievably therapeutic. Well, we can use technology to tell all our patients, "We've been thinking about you." It's back to what you were saying about your blood pressure, and we understand your work-life situation, and we've been thinking about you, right? So we have that ability to do it. That's fantastic. Let me go down one seat to Professor, and I've been practicing. Yafele?
Well done, David. Yeah.
Very good. Now, I've said it once, so now you're Eugene going forward. Okay, so thank you for coming over from Melbourne, which is an amazing place. And if the goal of this is to talk about what's coming, I know you have a lot going on, but one of the things that's coming is you're actually building a new big piece of your hospital. So how do you listen to the last couple days and think, are we building the right thing? Do we have the right flexibility? Is it big enough? Is it too small? Should we not build? How are you putting all this together as far as acute care, brick and mortar? And please go ahead and introduce yourself and your organization.
Brilliant, thank you so much. I'm Eugene Yafele. I am Chief Executive of Monash Health, which is a publicly funded, very large health network in the southeast of Melbourne. We have 26,000 people who deliver 3.8 million episodes of care. and that's 1.6 in the community, so out of hospital, nearly 11,000 babies, 82,000 operations, and 260,000 ED attendances. And listening to today, I think that what's absolutely clear in my mind is however great our hospitals are, and they are great, they are necessary but not sufficient to deal with this challenge. The southeast of Melbourne, and this is a story of two tales, if I may. The southeast of Melbourne is growing faster than any local authority area in Australia. So we have 600 people coming into that community every week on average. And you talk about building, we have built the Heart Hospital, which is state-of-the-art, the Teslas of hospitals. The facade of the hospital is a solar panel that insulates as well as harnesses our energy needs for heating and cooling. And as an Oracle partner inside the hospital, we have a fully digital, immersive experience for our patients and our colleagues. Real-time information on diagnosis, all the tests that they have, digital communication for the team, as well as ensuring that patients also have real-time information on what's going on for them. And I guess research is a central part of what we do. So through the clinical record, we have patients who are elected onto clinical trials or any other research activity. And we have an accelerator with the university where we want to translate research quickly to benefit patients and our population. And this is an amazing place which is there to provide, I guess, the pinnacle of cardiac services for the whole of Victoria. And this is where things start to come unraveled, right? The state of Victoria has 5 million residents. We know that in the next 10 years, the population that we serve in the southeast is absolutely going to grow beyond what we can build for and create the same sort of inpatient experience that we have. It's happening today. And I guess the question is, what have we learned from what we've done from an inpatient perspective, where we have a universal bed model that we can flex up and down without moving our patients? So we don't have a high dependency unit. We don't have a cardiac care unit. It's all there around our patients. And if we take that into the community, because health is made at home, and the pledge that we've made in Victoria is we want Victorians to be the healthiest people on the planet.
Well, you're going to have to fight us because we're doing it here in East Nashville, yeah.
We want Victorians, and it's not some Victorians, it's not most Victorians, it's every single Victorian. And therefore, we now need to take healthcare to the people. We need to be able to integrate, and this will be a game changer. We need to integrate care around our patients, their communities, and ensure that they have what they need to stay healthy. And how do we manage them in the community in terms of long-term conditions and keep them healthy, because we're deploying the digital capability that now exists. When Seema was talking yesterday, I think I lit up, because I can give you, and I need to get my currencies right, not £10, $10. I can give you $10 for every time a clinician says to me, what is it that we should stop doing? So actually, the one resource I want to give clinicians is time. Yeah. And the more intuitive that our digital landscape is for the benefit of patients through the clinician use, the better. And the best bed that people have is the bed in their own home, right? So actually, we can't afford to build another heart hospital or anything else that looks like it. But we can certainly look at how we optimize what's happening out there. Because as people who run and work in hospitals, we have a really unhealthy obsession with hospitals that we need to get over. It's cultural, but actually more and more we see that late diagnosis and things that are preventable if we are clever in the way that we deploy digital and use data and allow patients to be more engaged, which has been a theme in all these conversations, we will be able to look after every single Victorian.
Yeah, very compelling. It's fantastic. I had the opportunity to be in Australia a few months ago and was in Victoria, but also went to Sydney to a Med Info conference that was fantastic. And at that conference, I met with some potential customers from New Zealand. And they said that Australia's stealing all our nurses. And as I've had this opportunity in this role to go around the world, I go in these conference rooms and our customers or potential customers, they say to me, well, healthcare is different here. And I say, so what are your issues? And they say, well, we have trouble with staffing. Yep. Our doctors are burnt out. We got access issues. We have patient engagement issues. It is the same set of problems no matter where you are. Now, I hadn't heard Australia was stealing nurses from New Zealand, but nurses are being stolen from everywhere and just being moved around. Yeah.
I mean, healthcare is very global, right? And before I moved to Australia, I was in the English National Health Service. And my last conversation in my last organization where I was chief executive was in Bristol, which is in the southwest of England. And the last conversation I had in a staff forum was about car parking. As an inner city organization, it was about car parking, the charges, the inavailability of it, how we manage it for people on shifts. Fast forward a few months later, I'm in Melbourne. My first conversation with staff. And I'm thinking, I wonder what we're going to talk about. The first question, can you tell us what we're doing about car parking? And I thought, I'm home. I'm home.
You're an expert.
The issues are, we do think we're different, we do think we're special, but the issues are identical.
Yes, yeah. I think when you have humans set up healthcare systems around the world, they end up with the same healthcare system by and large. Mm-hmm. But that's a perfect transition to my friend Jeff Cardenas. So, Jeff, in that list where I go around the world and hear what's going on, once they talk about the car parking and the food, the biggest issue is staffing. 50% of the expense is staffing. And what also I think people that aren't in healthcare don't get is when I say I'm at 100% capacity in the hospital or 98%, that could mean that there's 4 beds left, but the staff for those beds may not match what that patient needs, right? So, but staffing. Jeff, you're a robot guy. You're a guy who's built a very successful company that uses robotics to help, and you'll give a better introduction than I can, but to help Mercedes build their cars. Introduce yourself, introduce the company, and then let's talk about how you think when you listen to folks like this, how you can help us with staffing.
Yeah, well, first I should say it's a real honor to be here on the stage with all of you guys as well and in this room. My name is Jeff Cardenas. I'm the co-founder and CEO of a robotics company based in Austin, Texas called Apptronik. The roots of Apptronik were a spin out of the University of Texas, the other UT for the Tennesseans around here, and work that we did with NASA to build what we call general purpose robots. So a lot of this technology had its roots in the wake of the Fukushima disaster to build a natural disaster response robot. The challenge was back then, and the challenge today was robots were very limited in terms of what they could do. So the sort of simple way of thinking about this is we have thousands of robots out in the world, and largely they do one thing. And our belief coming out of school and the work that we did in the laboratory was to build one robot that could do thousands of different things. A robot that could integrate and work with and around us across a whole range of different applications. So we started this company back in 2016. For me, the sort of intersection here is I grew up, my dad and granddad were both hospital administrators. My grandfather worked for the Joint Commission. My mom actually works for, it used to be called Truman, I think now it's University Health in Kansas City, as the chief administrative officer, so I grew up in hospitals. And as a kid, I grew up very interested in computers. And coming into graduate school, I was thinking, what is this next big platform shift? You know, what is the equivalent of the personal computer revolution for my generation? And became very interested in robotics. And kind of the frame to think about what's happening right now in robotics is we're essentially going from mainframe computers to the personal computer, to modular, more general purpose, more versatile platforms. And my dream and my interest is to put them into applications where they're going to be needed most to help humans. into healthcare, and so we can talk more about that as we get into it.
Cool, and I think we could show a video. I don't know.
Yeah, I have a video.
Maybe we could play the video, and here's the robot doing its thing. Maybe you could talk us through.
Yeah, so this robot's name is Apollo. I mentioned the history from NASA. It looks like a humanoid robot. You see it with legs here, but the idea of a general purpose robot is that it's modular, so it can go on wheels or legs. And the idea here is that we want versatility. We want a robot that can work with and around us in our environments that are designed for us. And we've been working on this, for the better part of a decade. This is our 8th iteration of humanoid here. We're now on our 9th, and we're just entering the stage where these are going from really the laboratory into the real world. What David talked about is we've worked with groups like Mercedes and across automotive to apply these to manufacturing and logistics. If you kind of use my analogy of the personal computer, you can think of this as 1982. So this is the very beginning of this technology being ready. But there's all this talk about artificial intelligence, and I just heard Larry talk about this previously. The frame to think about this is computers have now gotten good enough that they can now go from the digital world where they're trapped behind a pane of glass into the physical world where they can interact with us and be around us. And so you can think of this as a mobile sort of edge computer that can interact with around us and do a whole host of things. And I think it'll have big implications in healthcare.
Yeah, so I'm going to get to Hal, but then I want to ask you folks to tell Jeff where you would put your first robot. But the funny thing in all of this, I said, Jeff, can you bring a robot to the stage? And he said, well, our demonstration robot, I think, is in the UK right now. And I'm like, whoa, there's even staffing issues with robots. Like he's still, that's a separate issue. So we need AI around the staffing. Let me jump to Hal, and then we can answer Jeff's question. So Hal Wolf runs this global organization called HIMSS, which is really in so many ways, the thought leader and the measurer of how well we're doing in health IT. It's pretty spectacular. So a couple of things. I got a lot of questions for you, Hal, but I'll start with a couple. One, introduce yourself and do a better introduction of HIMSS than I did.
Oh, that was fantastic.
Okay. And then let me hit you with a question. Like to have you here on stage at the end, tell me what you're thinking. Tell me, with your experience and your vantage point, what are we getting right? What are we missing? What are you excited about? What's going on in your head?
In 30 seconds? I'm just joking.
You got 35 seconds. Yeah.
So first of all, thank you for the introduction with HIMSS. HIMSS is a global nonprofit, and we have over 125,000 members across the globe. And it really is a special society that pulls together a lot of thought leaders from every single component of healthcare. And so we really have an aggregated view that gives us and our tools and our measurements the opportunity to see where people are, to your point. I live in a world probably like all of us in healthcare, that one day we're highly inspired and the next day we're terrified, right? Because we recognize, and it was a point you brought out earlier, that the challenges of healthcare, no matter where we are fundamentally identically the same. We have aging populations, they're living longer, and so they're bringing with them a disease burden because A, they're living longer, they're going to get them, and two, we're a heck of a lot better at diagnosis. Behind that is a very shaky funding system, so we understand the pressure that we're on. We have an educated consumer who now wants and knows everything they can get their hands on through their mobile. And we do have a massive workforce shortage. And it's driving a lot of the challenges with all of our systems. I just came from Australia 2 days ago. I think I was 1 day ahead of you.
Yeah.
Is that about right? 20% of the GPs and 20% of the nurses in Australia will be retiring in the next 10 years. And that does not include the ones who are opting out of the system as we speak. That's not unique. US has about the same figures. So we are seeing this wake-up call to the use of digital health and the use of information as a means to monitor individuals at home, to change how we practice, because it's not enough to throw technology at it. We have people, process, and then the technology. The technology is coming along fine. Your announcement yesterday was a great example. Fantastic step forward. AI is filling in operational roles. This ring is measuring blood pressure. We talked about this last night. And I see a number of people here that have some rings that are, measuring their sleep and their walking patterns or their watches. So the culmination of what we're beginning to see is this absolute need to take digital health, combine it with AI by grabbing a hold of the data, turning it into information, and begin to do the predictive modeling at the individual level. Larry used an incredibly important word in talking about AI right out of the gate, which was anomaly. AI looks for the anomaly, right? Patterns with anomaly. That's healthcare. We all have a definition of norm, and we look for the anomaly against that norm. And when we can define it, we put people on a care pathway. So the earlier that we can bring someone in and detect that anomaly at home through their own devices and their own ecosystem, the better we can prioritize those precious resources for the encounter. So we're really beginning to see an outside in, the need of the longitudinal record, the infrastructure, and the fundamental data point to complement the EHR. And David, as you and I were talking about a little earlier, thousands of data points coming in from multiple locations, which we now need to manage. And finally, the knowledge management itself. So if I go back 1972, I've got 4 major general journals in the world, and if I'm a physician, there's about 400 peer review articles per year. I can read an article a night and keep up. There can be about 10,000 this year. So without the knowledge management, combined with the information, combined with the AI, and care at home, this is the only way that we can see this keeping up. So now we're measuring what Europe is doing, which is their version of meaningful use. We're looking at interoperability across the globe, and we're seeing a concerted effort to say, here's my workforce, how do I extend it, and how do I bring it back in? So it's a fascinating time.
What does HIMSS Level 7 look like in 10 years from now?
It's what? I'm sorry.
In 10 years from now? What is it going to be? So I was with CAMH earlier today. They're, I think, the first mental health hospital that's ever got to HIMSS Level 7. Amazing place up in Canada. So HIMSS Level 7 is the ultimate, right?
Yep.
You hit HIMSS 7, you get to have a party at your place. And there's usually Cinnabons and stuff.
It's a good party.
It's a good party. But what does it look like to be that digital pioneer 5-10 years from now? Because it's the criteria of current HIMSS 7 is not going to be the criteria.
Right, it won't be. If you look at a HIMSS Level 7 facility today versus 4 years ago, it's 4 years ago we were measuring technology. Now we're measuring technology and its impact on access and quality. Then we're going to be looking at continuity of care. So how do we bring social determinants of health into it? Health equity is at the core, right? We have to use the system to be able to outreach, because access is going to continue to be a critical challenge. And by the way, that's not just rural. That's within the city itself, as you fully well know, right? Up in the section. So when we start to look up and we say, okay, how am I going to gain access? So what HIMSS is going to continue to do is this: pull together the thought leaders from around the world, see what's working and what isn't, share best practices. But we continue to lead from an advisory standpoint, which we're very proud of, this recognition that the utilization of information and integrating it into how we run our health systems is the key. It cannot be. There's a really cool formula, which is NT plus OO equals COO. And that means new technology plus old organization equals costly old organization, right? And if we don't change how we deliver, then we're running out of people.
Yeah.
But Eugene hit it, right? I can build all the hospitals I want. I can't staff them. So how do we make sure that we integrate and engage the patient? This is patient care.
Yes.
At its absolute starting point, measuring that and helping healthcare systems guide itself. I think in 10 years today, if you look today, about 5% of the healthcare systems can really deploy and utilize AI, just about 5%. I think in 10 years, you have to be somewhere in the neighborhood of 50 to 60. And I'm talking globally.
Yes.
Right? And we've got way too much of a disparity between the industrial nations and the non, but they're beginning to catch up. And we work very closely with the WHO in Europe. We're extending it into South America now, and we're beginning to bring those technology organizations like yourself and others to bear so that people can catch up. And they have a wonderful advantage in the sense that systems that are beginning to deploy now get to learn from all of the mistakes and the opportunities we've had in the past. And that's a great advantage because it's all about sharing.
Beautiful. Great. Thank you so much, Hal. So we got probably another minute or two to do a little rapid fire. I'm going to tell you I've come up with what I've learned in this panel, what I've learned in the last couple of days. One, we can help with the staffing issue. My wife's a pulmonary critical care doc. The team sent me the demo they were going to show this week on the EHR, and I showed it to my wife last weekend, and she said, I'm going to unretire. So, which I don't want her to do. But if we can make that workflow easier, we see folks who'll go, hey, I could still be a nurse for a few more years because the pain is gone. The other piece, I think, and I don't know how fast it comes, is using your robots. And so I'll go first where I would want your robot to go. Because I think most people would say, well, we'll hear what people say, but we could use them in sterile supply or helping in the OR or on the loading dock. I think loneliness is a big issue, and they, in some ways, can become a companion for someone at home to prevent them coming in. So that would be my pick. But I'd love to hear what other folks would think about if Jeff showed up and said, hey, we want to deploy 1 or 20 or 100 robots, where would you go put them? Go ahead.
Can I give a quick frame to think about this too? I think
we're not holding you to this, Jeff. You're not going to have to.
I think one thing to think about too is tasks versus jobs.
Yeah.
If you look at some of the statistics I've seen is we're going to face this massive nursing shortage by 2030. And I think an interesting question is why? What's driving people out of this field? And if you look at what a nurse does, a huge part of a nurse's day is doing things that have nothing to do with their clinical training. And ultimately, I agree with what everybody's saying here. This is about patient care. This is about humans taking care of humans. But we don't have that today. My mom's hospital, a lot of this is about telehealth and putting screens in rooms and other things so that you can provide better access. So I think just think of the frame, too, as not a direct replacement, but how could you put a robot with a nurse such that you could offload the worst part of that job and elevate the types of jobs that we're doing and deliver better patient care?
Much better framing. Go for it, my friends. Any order, jump in.
I'll jump in.
Okay.
I'm in the business of training health professionals, and what came to mind is my students and residents, they have to know procedures. They do. Because when things break down or where they're in communities where they don't have access, we want them to know procedures. And I could see the use of a robot teaching procedures.
Yeah.
I can visualize it.
Beautiful.
So that I'm not trying to get faculty all the time in certain places, but the robot is there to teach, to demonstrate, to put examples in. And I can see the excitement on my learners' faces about being able to interact with that robot.
Yeah. Love it.
I would go with task devices, like the rings we wear and such. We are talking about a shift in scope of practice. That's really what it gets down to.
Yes.
We made that shift a couple years ago, doctors to nurses, now nurses to devices. We have to spread those amazing resources and precious resources out at the highest level of their practice. And I think it'll be an absolute combination of the two, at home and back through to the hospital.
Beautiful.
Absolutely agree. One of the things that we have with 260,000 ED attendances is constant patient monitoring, which is difficult and sometimes not giving us what we need. So if we can get robots strategically placed in the emergency department, taking vital signs, looking after patients, telling us what's going on, I'll certainly sign up for that. And car parking.
Parking, of course. Well, I think we're going to have cars that are driving themselves. So we got that one. General.
And I think I put it with our medics on the front lines.
Beautiful.
To do some of those tasks, but to also help them move at the speed that they're going to have to do. There's a lot of repetitive things that robots could absolutely help all our medics on. I imagine you can visualize that in a deployed setting.
I love it. Well, thank you, because those were not in the prep questions. So I appreciate my panel being so flexible. So we're out of time. This wraps up our 2 days here. And on behalf of everyone, first of all, thank you to an amazing panel.
Thank you.
And thanks to all of you for going on this journey with us. It is really, really an exciting time for me to be at Oracle, because with the different opportunities that I've had, seeing it all come together, the tech at this time, the resources, the constant kind of being open, connected, the partnership success, I hope you've enjoyed the last couple days as much as I have. So thank you all for coming, and safe travel home. And thanks again.
Thank you.
Thank you.